At SITC this year, we presented our retrospective analysis on genomic and immunophenotypic correlates of acquired resistance to PD-1 blockade in non-small cell lung cancer. And we have really tried to learn more about primary resistance to immunotherapy in lung cancer over the last years. And we've identified several biomarkers that may predict response of primary resistance to PD-1-based therapies in patients with metastatic non-small cell lung cancer. However, we really have very few information of the mechanism that may potentially drive acquired resistance to immunotherapies among patients who initially respond to these treatments and then eventually develop disease progression. And so to address this question, we try to leverage an institutional cohorts of patients with metastatic non-small cell lung cancer who had pre-treatment and post-treatment tumor biopsies, then experience an objective response between the two tumor biopsies. And so we identified a total of 80 patients with intervening immunotherapy between the two tumor biopsies, and 77 of these patients had enough tissue for comprehensive tumor genomic profiling, which we did using our in-house NGS OncoPanel platform. And when we compared the genomic profiles of patients with pre and post immunotherapy tumor biopsies, what we found was that there were several recurrent alterations that we were able to identify in resistant immunotherapy samples. Particularly, we found loss of function mutation in genes, which were previously being reported as mediator of primary resistance to immunotherapy, such as STK11 or LKB1, KEAP1 and SMARCA4. But we also noted acquired loss of function mutation in genes such as beta-2 microglobulin, which is a critical protein necessary for antigen presentation. And this was previously reported by a group at Yale in 2017 in a small case series of patients with non-small cell lung cancer who had matched pre and post immunotherapy tumor biopsies. And so our data are in line with that smaller study. And this was recurrent because it was found in 5 of these 77 patients. In addition, we also noted a loss of functional mutation in JAK1, which is a mediator of interferon gamma pathway. And again, this alteration has been previously reported in melanoma patients by Anthony Ribas' group, has potentially driver immunotherapy or acquired resistance. And so we were able to identify these alterations. But in addition to mutations in these genes, we also were able to find acquired copy number alterations, which is something other studies really didn't focus on. And we noted again that where a significant amount of patients had acquired copy losses, homoheterozygous losses, or homozygous losses in several genes such as STK11, KEAP1, SMARCA4 again, but also beta-2 microglobulin, PDL1 and PDL2, which are two critical biomarkers of response to immunotherapies. And previous data from our group and others have shown that copy losses in these genes do associate with resistance to immunotherapy and or lower PD-1 expression level. And so we noted also this alteration. We tried to expand our analysis on immunophenotypic correlates of acquired resistance by also looking at T cell count and immune cell subset count in previous post immunotherapy samples to determine whether there was any change in immune cell subset between these samples. And so in a subset of these patients who had tumor biopsies pre and post and had hematocytic eosin stain slides, we leverage artificial intelligence and machine learning algorithm to calculate and assess the density of tumor-infiltrating lymphocytes pre-immunotherapy and at the moment of acquired resistance to immunotherapy. And what we found looking at this question was that at the moment of acquired resistance to immunotherapy, there was a significant decrease in lymphocyte count within the tumor. We also looked into control cohorts of patients who did not receive immunotherapies, but did receive chemotherapy or targeted therapies between the two tumor biopsies. And what we noted was that in these two control cohorts, there was no change in any of the genomic factors I mentioned before, but also there was no change into the tumor-infiltrating immune cell subset count in terms of lymphocytes. To further characterize these immune cell subset, and particularly these lymphocytes, we also performed multiplex immunofluorescence on the same samples pre and post immunotherapy. And among patients with enough tissue for this additional analysis, what we noted was that specifically CD8 positive T cells and CD8 PD-1 double positive T cells significantly decreased at the moment of acquired resistance to immunotherapy as opposed to the baseline samples. And as last analysis, we also tried to look into the HLA class 1 expression, which has been previously reported as potential biomarkers for response and or resistance to immunotherapy based on expression levels. And our hypothesis was that at the moment of acquired resistance, we could potentially see a decrease in HLA class 1 expression as previously reported in other tumor types. So we performed immunohistochemistry for HLA class 1. And what we noted was that in patients who received immunotherapy, at the moment of acquired resistance to this treatment, there was a significant decrease in HLA class 1 expression as H-score. But again, when we look into our two control cohorts of patients who did not receive immunotherapy but received chemotherapy or targeted therapies, while in these two control cohorts, we did not observe any change in HLA class 1 expression, suggesting that this change may be specific or more unique to patients who received immunotherapies. And so in summary, I think our data suggests that we can identify mechanisms of acquired resistance to immunotherapy. This can be heterogeneous, potentially encompassing mutation, copy number alteration, but also immunophenotypic changes in immune cell subset or HLA class 1 expression. And so maybe relevant in the future to whenever feasible to profile these tumors at the moment resistance has this information can inform treatment decision, but also can help us designing the next generation of clinical trials in the immunotherapy resistant setting in patients with non-small cell lung cancer.